get outside from this debate by more questions than answers. We aim to increase the exploration of the topics of the antimicrobial stewardship as a whole, and especially in the critical care setting. As usual, please scan this QR code to have the poll done in the following questions. And of course, we will have the answers from our respectable panel. So, should we give antimicrobial or antimicrobials to all ICU patients? Yes or no? What do you think? Does the admission to the ICU by itself is an indication for the for antimicrobials? يعني طبعا واضح ان انتوا سيطرتوا في الثلاث دقايق دول. اجابه ممتازه. كله نو. كويس. بس do we really see this in our hospitals? Do we really see this in our hospitals? طيب what do you do? الدكتور مصطفى دايما بيقول واجب الرعايه، يعني بيقولوا ان عندنا what's the experience in عمان دكتوره فريال regarding في مايك يا زعماء، انا كنت سايب مايك هنا.
We said there is the practical part and there is the theory part. We all agree that there is not every patient in ICU will require to be on antibiotics, but the practicality is it seems that everybody who enters the ICU will say there is a small fraction that leaves without being on antibiotics. And the reason is because there are multiple other things that happens, the dynamics, such as inflammatory syndromes, or SIRS, other sepsis. All these are manifestation typically would happen in the ICU and would push the clinician to start an antibiotic. The threshold is very, very low. And that also happens in my ICU. We did an audit, a small audit in our hospital to see who consumes meropenem the most. And we found that the highest consumption of meropenem was in 3 specialties: ICU, hematology, oncology, and then nephrology. These are the 3 specialties. And those 3 specialties were the target for our stewardship activities because they are using the most of antibiotics. If it is meropenem or tazocin, they are the highest consumption. So this is nice. Everybody said no, but on practical side, lots of consumption in ICUs.
So Jamila, can we give some examples to ICU patients who do not require antimicrobials?
Yeah, absolutely. I just, probably agree what Dr. Farial mentioned. I think the admission to the ICU, it all goes back to what's your diagnosis and admission. So that has to be the initial. Okay, so then when giving antibiotic, you have to decide about what group, why you are giving. Is it prophylaxis because those patients are immunosuppressant, they have to be in certain antibiotic? That's, we cannot do anything about it. Then empiric, and I think that most of the cases, the ICU, because they come to us in shock stage, and we don't know it's septic, it's cardiogenic, it's anything else. And this is where the vague, decision whether to start or not to start, and what to start. And I think the problem in the ICU is not only starting antibiotic, it's the broad spectrum antibiotic, and most of the patients are in 3 or more antibiotic. That's the biggest problem, actually. It's not
we will go into this.
And then for the cases that we should not actually use, which are clear-cut. For example, patient coming with, myocardial infarction, heart failure, that's clear for everybody. They will not start antibiotic. Other coming with fracture, multiple fractures, but not open. So probably they will not use it unless he go for surgery. There are a few which is very, crystal clear that they will not use antibiotic because they don't have that reason to give.
أيوة.
So it all depends about the intensivists, how they evaluate the case on a spot. They risk stratify these cases and decide whether to give or not to give. And I think, and this is, I say it all the time, even for the resident and the students, actually giving antibiotic decision is much easier than not to give. Not to give, you should be very strong in your knowledge and your science, because that's where we have to have the all, because anybody can give any antibiotic.
Okay, so that's very nice, and I totally agree. You have to be strong in your science, and you have to be strong in knowing your patient. This is another issue. History, clinical examination, and radiology before deciding. And I will give you examples. We admit patients with stroke in our ICUs for only observation, guidelines of the ASA or AHA for 24 hours for observation. These patients do not require any antimicrobial. These patients are there for neurological observation only. These patients, unfortunately, in some of our ICUs actually receive meropenem, for example, as not to increase the likelihood of convulsions. And so you go into step by step for adverse effects, actually, not for an additive or beneficial effect. Patients with DKA because they missed their insulin dose, not because of infection. And this means that you have thoroughly investigated your patient and know that the cause is that the patient actually did not receive his regular dose of insulin. These patients do not require any antimicrobial. And I can give you lots and lots of these examples. Shock can be caused by allergy, not by infection. And patients allergic to a drug or a food should not receive any antimicrobial. This is point one, and I hope that we can, even if we reach this percentage, that will be very nice.
دكتور عادل أضيف برضه حالتين، وأنا جربت ده في العنايات الأماكن بالذات الاستراليزيشن والفلو هادي شوية، فبنقدر جرانتي التعقيم، زي حالات الهيد تروما. عيان هيد تروما والجي سي اس كويسة ومفيش أي ريسك اوف اسبيريشن. sometimes I withhold antibiotic. acute pancreatitis which is caused by non-infectious causes. أنا بحب إن أنا أضيف بعض الحالات برضو علشان كلنا نتشجع إن can we فعلا withhold الانتيبيوتيك وبروتكت العيان وكونسيرف حاجات كتير بإن احنا withhold الانتيبيوتيك. الإجابة يس، زي ما أساتذتنا
يعني if we reach the head trauma that would be very يعني nice really يعني. So
I do it. أنا فعلا
that's very good. So as Dr. Gamila said, we will go into the most of the patients in the ICU will have the empiric indication for antimicrobials. And when we think empiric, again, we have to try to localize the infection by the history and the examination and the radiology. We have to see what are the most probable pathogens, and we have to put drugs that attack these most probable pathogens, of course, in the environment of the ecological of the hospital or the institution. What are the prevalent organisms and what are the most sensitive antimicrobials? Does anyone know what is the carbapenem resistance in the Egyptian universities, including Asyut, Ain Shams, Cairo, and all of these? Does anyone know the prevalence of or the resistance rate of carbapenems? It is 63. 63 in the most recent five university studies. Actually in collaboration with Bahrain also and Oman. So it is 63. So we all try to reduce the exposure to carbapenems. And the question to you, as you have answered, what do you use as carbapenem sparing? Most of you said we use piperacillin tazobactam. A minority used other. What other drugs do you use? Cefepime. Good. What else? What? Ceftazidime alone. Fine. لا outside the urinary tract. urinary tract اصله قصه لوحده. So, Dr. Farial, what do you think about using peptazo in the as a sparing for carbapenems?
So we talk about an important concept, how to reduce resistance, and resistance is associated with overuse of antibiotics. And when we talk about CRE, it's clearly use of carbapenem. So the strategies, there are multiple. One of the most important strategies, infection control measures, and I hope we should not forget that always when we mention strategies. But when it comes about drugs, piperacillin tazobactam is one of the strategies to spare, but we do few important facts are important to remember. Number one, that there are certain studies like Moreno study, despite the limitation and the type of the study, it was a wide multinational, multi-international study that showed when you use tazocin in patients with bacteremias related to ESBLs, I want to talk about ESBLs, and particularly there was increased mortality. So we have to divide organisms when we talk about carbapenem sparing strategies into number one, ESBLs and non-ESBLs, because for CREs anyway, you cannot do carbapenems are resistance and you will not be able to do them. So when we talk about ESBLs in particularly, if we have bacteremias, bacteremias, majority of the data currently, the current data support using carbapenem here. Or beta-lactamases, the newer beta-lactamases inhibitors. And I come to that in detail. When we talk about urinary tract infections, ESBLs, then there is a room for piperacillin tazobactam. And there is now emerging data, if you have even bacteremia, but it is from urosepsis related to urinary tract infection, and the MICs to piperacillin tazobactam is less than 4, and the infection is not severe, you can use carbapenem sparing strategy. You can use piperacillin tazobactam. So we talk about urinary source, we talk about biliary source, we talk about MICs. You have to know your MICs, and they should be less than 4. And we talk about not very severe infections. So low severity to low moderate severity of infections. Apart from that, remains carbapenem would be the way, one of the options where you can use. When we talk about the newer agents, ceftazidime, avibactam, or ceftriaxone, tazobactam, and here we divide into ESBLs. There is, and we have certain situation where we can use it. We use it into intra-abdominal infections, urinary tract infections. All these R's we can use for ESBLs. So that's ESBLs. When we talked about CRE, in CRE specifically, we cannot use carbapenems because they are resistant to it. So we are ending up with other options. So what are these options? We heard about colistin or polymyxin and the problems in identification in the lab because there is no fixed definition to the breakpoints, and that's why it's very labor intensive in the labs to do the sensitivity. So the other things for colistin is the side effects that is related to the use of colistin, the nephrotoxicity. And also these are very old drugs that we brought them from 1940s, and now we were utilizing them because there were no other options. With the newer drugs, we look into what is predominant in our part of the world. You share the same thing as we do in Oman and Bahrain and GCC. And in India, we have predominance of OXA48, and we have predominance of NDMs. And those usually for OXA48, ceftazidime, avibactam, and for NDM we are using estrinam. When it comes to, KPCs, ceftazidime avibactam is a good option, and KPC is mostly predominant in the Western countries, but you might be seeing it as well. In Oman, we don't see that much of KPC.
Dr. Jamila, what about using cefepime as an alternative to carbapenems in severe patients admitted to the ICU?
So that will go back to the same, basic information that Dr. Farial just mentioned. It depends the site of infection, the type of the gram-negative you are talking about, and if it's ESBL or non-ESBL. So you can use it. It depends on the, as we said, where is the infection? For example, cefepime will work very well, even if you have, intra-abdominal infection, bacteremia, yes, with the enough doses, taking all the pharmacodynamics and kinetics into consideration, yes. But if you want a broader coverage for something and your patient, like previous culture, colonized with something that's already CRE, that will not be an option for me.
Good.
The patient coming from the community with most likely a community-acquired count of organism and pan-sensitive, yes, it can be. The other thing that probably, people, just heard about it before, even within the carbapenem group, there are a lot of studies that have proven that the ertapenem is less kind of induction for the CRE problem. So it's really a kind of sparing. It's within the carbapenem group, but it's a sparing. And it's good to use it because once a day, it depends if it's available, you use it. The other thing probably, which probably add to what Dr. Farial mentioned is if you have UTI, even if it's ESBL, we have the fosfomycin option, which is good really, whether it's the oral, and if you have a severe infection, you can go for IV. That's where you have to go. The problem, we go back, it's what's the first option by the intensivist or the nephrologist. They love meropenem. And it's not even imipenem because they get used to prescribe meropenem. So they just love it and they're comfortable with it. And that's what we have to change over time.
So bottom line in this one is that we have to think about alternatives to carbapenems because we are abusing them extremely. Not even if they are indicated, the only indication, the real only indication empirically is that the patient is shocked and the probability of ESBLs especially are the number one. ESBLs number one, yes, you should use carbapenems.
Just add one point, and I think that's where our intensivists really probably are worried, is that if it will affect the mortality, and when you go and give a decision, you are worried about this legal. You stop the antibiotic, not me. And this is the part we want to make sure. I remember when we started, our stewardship in our ICU, that was in 2010, 13 years ago. And we started in the ICU, and it was a decision, this is what we're talking about, it was me and one resident only. And we work within the ICU because we know most of them are more than 3 antibiotics, and they give them for long times, even 2 weeks, 3 weeks, they continue using the same antibiotic. And what we found, we were able to decrease the consumption of antibiotic in the ICU by 75% over 6 months with a lot of save of money. And this is where administration know, and the intensivists, they know you don't have to use it to save patient. You should use the right choice. And this is very important.
Definitely. We want to improve the outcome, and I will show you that the AMS or the antibacterial stewardship programs actually improve the outcome. They do not decrease survival. They actually improve it. And we will go to this. Third question is, when do you use new beta-lactamase inhibitor drugs? When? Do you use them by any chance anyway؟ مين يستخدمهم؟ مين يستخدم سيفتازيديم افيباكتام او زيرباكسا اللي هو السيفتولازون تازوباكتام؟ 1 2 3 4 يعني في عدد كويس. A is empirically, B is documented or whatever. C only if the risk of mortality is so high, and D, they are too expensive. We have, I think yesterday we have talked about being expensive as related to the current rates of financial burden of the ICU itself in Egypt. They are not expensive. If you can decrease 1 day of ICU stay with these drugs, they are not expensive. So this is always, but we have to use them in the proper position. So you think that you have to use them only if there is documented or suspected infection in a colonized patient with no other option. These are the most current drugs. Dr. Ahmed, what do you think?
الحقيقة أنا استعملت ceftazidime افيباكتام بس I have never used it without يعني
Documented infection.
البايوفايل.
Okay.
Other than this, I will not by any way lose it. لأني لو استعملته خلاص ده آخر باب قدامي. If I use it improperly, I will lose it and lose my patients.
طيب Dr. Nermin, do you restrict their use in your hospital?
Yes, actually, the two, if we are talking about the ceftazidime avibactam and ceftriaxone, yes, both of them, they are restricted, or we are restricting them because the physicians in the ICU, they are tempted to use it empirically sometimes, although we have other options can be available for the patients. I know that some of the guidelines introduce them empirically, but whenever we have other options, we prefer to go to the other option and spare them.
AMS-wise, till now, they should not be used except with documented or suspected. AMS-wise, at least. Dr. Afriel, what's your practice?
Yeah, it is also restricted in my hospital. Both drugs only ID can prescribe. And it's, as Dr. said here, Dr. Imad said, it's an important, I will say, last resort that we are using. So currently, though there is sometimes guidelines or temptation to use it empirically, currently the use of it is targeted therapy. When we have a positive culture, we use it. The only situation sometimes and needs to be after discussion with either the microbiologist or the infection disease consultant is when the patient has a risk factors for, for CRE, for example, and non-risk factors, maybe prior colonization, when while you are waiting for your test to be ready, and that time you may be septic, you can use those empirically. But those are very, very limited situation, and it's not as a strategy to spare the use of carbapenem. It's an early empiric therapy based on risk factors of that patient and prior colonization.
Dr. Gamila, what do you practice?
I'll just probably echo what Dr. Farial. I think this is very important. Yes, it's most likely will go as a second lines when you have but there is a cases where you do by risk stratification. The patient has the risk factor to have those CRE, or even most of them we have now with a kind of pan-resistant kind of organism that you see once in a while. So if you see your patient, and there are in the literature here, there's different scoring system that you can use it as a first agent. So the common, most of the cases, yes, probably yes, but we have the patient with repeated infection. He's been, this patient has been in the ICU last, 2 months ago, and it was KPC, or whatever, you have, it's CRE, different type, and that he has still leakage from biliary. That's where the case you will start it. It should be restricted. We totally agree. In our institution, it's restricted. It has to be by ID. But what we did, because of the limited infectious disease available on call 24/7, that we lifted for the ICU, basically hematology oncology, consultant to prescribe it for the first 48 hours. So it's their decision.
And then this is reviewed.
Then reviewed and approved. Otherwise, it will be DC'd by the pharmacy. Okay. So this is where we give them some kind of space to make their own decision. They do, the patient will not die because they cannot probably reach us, or whatever happened. So they can make the decision. But most likely it will be kind of second line agent, but there are certain, and it's as small as Dr. Farial, but this list is increasing. When we have, ceftazidime avibactam initially in our hospital, we use it for a couple of cases, but the number is increasing because that resistance is increasing. So more cases we are seeing.
Please.
أنا عندي سؤال. Say إن أنا started في بعض الحالات within the context of the case as you mentioned. واضطريت الحالة very risky, very septic. وفي ريسك فاكتورز زي ما حضرتك قلت، وبعد كده عملنا الكالتشر والسنسيتيفيتي، طلعت حاجه تاني يعني اقل، say انه فورس جنريشن كيفروسبورين اور وات ايفر يعني. وانا كان ليا 3-4 ايام ابتديت السيفتز في السيتويشن ده. اي سويتش بقى للحاجه اللي هو حاجه مثلا زي الميروبينام او الارتابينام او ايميبينام، ولا اكمل عليه الكورس. انا ده سؤالي، اكمل الكورس بتاعي بقى، انا مضطر اكمل الكورس ولا انزل؟
دكتور جميل عزيزة.
You know, it depends on the case. So most likely because it's a broad spectrum and use it because you have to use it. If you get the culture it's pan sensitive, you can just switch it, especially, you know, if it's bactericidal and you want to go ahead, because, you know, I think you mentioned it at the beginning of your comment. You don't want to lose them. At the end, they are beta-lactamase. And any antibiotic you have new, they are not a new antibiotic. They are not the magic bullet for all our infections. So save them for some patient. If the patient is not that sick, they don't have, and you are almost like sometimes happen, the patient has been in the, you know, ceftazidime avibactam for 5 to 6, and the repeated culture initially reported maybe not, and you get the culture by the 5th day, and you're already finishing the course. You know, that's another case scenario. But otherwise, this is the de-escalation we talk about in the stewardship, and that's one of the elements of stewardship. Within the ICU, this is the rule, our friends in pharmacists. This is the people that really back up us in all decisions.
And actually, I need to add that normally we have this misconcept that if I'm starting the course, I need to complete the course. It doesn't go this way. This is the aim of the de-escalation again and the timeout, and to revisit the antimicrobial being started within 48 to 72 hours. So nothing said, nothing to say that I need to complete the course because I've just started it.
So regarding new drugs, they are not a part of the carbapenem sparing strategy. They can be indicated according to the resistance mechanism with documented or severe suspected infection in special cases where your patient, you know that he is colonized or had a recent previous infection with a CRE or a KPC or whatever that requires these drugs especially. And always we should be restricted. 4. In empirical treatment, do you prefer more monotherapy or combined therapy, combination therapy? What do you think? Ahmed, what do you use?
ده سؤال مهم جدا، والحقيقه طرح في مش فاكر الريفيو، لسه الريفيو ده نازل في 23 عن الانتيبيوتيك stewardship في الاي سي يو. I will use combined therapy in the very critically ill patient, very septic patient, septic shock. ومتوقع ان ممكن يكون في multiple organisms او في risk factor او عيان على renal replacement therapy او كان admitted في الاي سي يو قبل كده وخرج ودخل يعني abdominal operation والعيان contaminated surgery. I will use combination even triple antibiotic. ده رأيي.
تمام. دكتورة فريال اتفضلي.
So again, when we look into the use of single drug monotherapy versus combination, most of the data available on combination therapy did not show superiority over monotherapy in many infections and diseases. In terms of, if we take even febrile neutropenia, there are good data that monotherapy is equal to or the outcomes in terms of length of hospital stay, mortality is no different than single agent. So we tend to go over combination. We have this feeling that the more we give, the better it is for the patient. And I wanted to go back into not just risk stratification of the patient, this is sick patient, he had surgery, but also thinking like working similar to Sherlock Holmes, what is the most likely pathogen this patient is having epidemiologically, risk factors, prior colonization, getting the pathogens. If you get the pathogen, then it's easier to decide, am I going to do single drug or I'm going to do combination treatment? So in my opinion, the data have been more favorable for combination therapy in certain situations. Number one, neutropenic patient with Pseudomonas infection. So neutropenic patient, when they come, maybe there is a room for combination therapy. If I know that they have a bacteremia, even upfront, there might not be a room for combination therapy. Patients who are colonized or have at risk of CREs, those are the patients or multi-drug resistant Acinetobacter infections, because combination therapy here maybe is better than monotherapy. So very few situations where I go to combination therapy. I try most of the time to nail it down to what is the risk factor of the patient and what's the most likely pathogen. And here I do select based on that. Even in septic patient, the guidelines, you have to look into your local epidemiology, what is predominant in your ICU, in your hospital. Because, for example, in my hospital, in my ICU, we have certain percentage of resistance, CRE percentage of resistance. So upfront, I might not do combination, but if you have high rates in your hospital, in of your unit of CREs, you might want to double cover. But apart from that, very limited situation when you need to do it.
Normally, when we are thinking about the combination, we do think about that we need to broaden the spectrum, or we need to synergize the activity of other medications, or maybe reducing the resistance. But the problem always, we are ignoring that combined therapy is accompanied with more toxicities and accompanied with more adverse events, super infections, increasing the cost of the therapy. So normally we do not balance this. So we need to think about the balance. As the doctor said, that there is no confirmed thing to start with a combined therapy unless we have a clear indication for it, and they are minimal cases.
I'll be like, the devil advocate. I think just we have to be careful. What you said is absolutely right. And what, my colleague said is absolutely right. There are certain, when the patient, and this is, I say from ICU point of view, when the patient come to the ICU, and I know for sure it's a septic shock. And probably with the stewardship program, the whole thing, the whole initiative, when we talk about them, number one, what's the most difficult part is the right diagnosis. So once you decide about empiric treatment, you should know what you are talking about. So what Dr. Farial mentioned, and the opinion about it's mainly monotherapy, yes, in most of the cases, but the septic patient is coming, and I know it's intra-abdominal, I'll use combination. If I know the patient has been colonized before, I'll use combination. If I know that geriatric, like probably if you attend my presentation yesterday, most likely they have a gram-negative, but they may have a gram-positive, because you'll never know the source of infection unless it's clear, it's a UTI or pneumonia. I'll use combination because I don't have time till I get the cultures back. And this is the main problem we face. The worst thing, you want to see if the patient gets to your ICU, and this is not the other cases, because what mentioned from the other point, we go, as an ID, I go with monotherapy most of the cases. Really, it's the exception. But you have to be very careful. You need them in certain cases because you have that window period. You don't want after 2 days, the patient's still sick and the culture comes something else. So this is the combination, but it's not the usual. It's not the norm. So it comes back to what you have, what kind of cases. If you're in the ICU patient, it's septic shock, you are sure it's septic shock, and that's probably ruptured bowel. No, that's combination. There's no question. Nobody will say, even the ID or the pharmacist will not say anything about it. The other milder cases that you have time, you can decide, it's UTI, most likely E. coli. Yes, that's one monotherapy. So make sure your diagnosis is right and you are quite confident what you are deciding. And believe me, there are in the literature a lot of scoring system and algorithm and pathway that help you in making the decision.
Yes. تمام.
يعني أنا عندي طرح برضه صغير إن إحنا بنتكلم على حالات admitted in ICU not in the ward. So العيان اللي هيدخل لي ICU وشوكت ومش كاردياك ولا allergic ولا hypovolemic is in intense need. ثانيا هذا المريض غالبا بيبقى عولج بره وخد antibiotics كتير وترايد ممكن this is the reality يا جماعه. احنا بنتكلم
ايوه
على
this is by itself is a risk factor for NDR.
داخل لي شوك وهديله مثلا just سيفتراكزون.
لا the shocked patient we agree all.
اوكي. ما انا ما اقصده هو الواقع بتاعنا. انا بتكلم كمان على الرعايات الجراحيه. انا بشتغل اكتر حالات سيرجيكال. فالسيرجيكال الكومبليكيتد دي غالبا زي ما بتقول دكتوره جميله مش بينفع فيها. فلازم نبص على الكونتكست بتاع الحاله.
Just one thing, just to add what just mentioned. We usually have a problem not with the idea of combination, it's what's combined there.
Definitely.
Believe me, when you go as infectious disease pharmacists, we really just, why this plus this? It does not work. You are overlapping. Your combination, most of the time, it's not yours, but most of the time when you go to the ICU, the combination is a wrong combination. That's our problem, really, because we know that the first hour, few hours, we give the luxury, use whatever you want to use. But when we go, we will get shocked, like patients, meropenem, tigecycline, and Flagyl. I don't know what they are treating, really. And this is where we come to really reshape it, look at, risk factors, cultures, procalcitonin level, other parameter, colonization, and we try to give them advice how to adjust it. So the combination is good in those cases, but be careful what you combine with what.
And we cannot ignore that there are guidelines for certain diseases that actually start with combination therapy. So hospitalized CAP, for example, should be with at least 2 drugs. This is another issue. Especially pneumonia, it's the same. Does combination therapy reduce or increase resistance?
I think we need to define what is combination therapy as well, correct? So sometimes there is the double coverage, sometimes there is the combination treatment.
Broadening spectrum.
Broadening the spectrum. And sometimes it's an important combination for synergy, like infective endocarditis,
Yes.
like tuberculosis. So that's why we say we have to think of the pathogens whenever we are deciding whether we need a combination therapy or not. So the matter is not, how many drugs we are adding. The matter is what we are covering and how we are covering.
I'm asking this because some of our colleagues think that having combination therapy reduces resistance, which is not supported by any literature whatsoever.
Yes.
That's why I wanted you to elaborate on this.
Definitely, answer is no. It
Yes,
does not
no.
reduce
Thank
resistance.
You.
Yeah.
So, what does de-escalation means, Turner mean?
De-escalation means that once we started to have a clear response from certain medication, and normally when they are broad spectrum,
clear clinical response.
Clear clinical response, or we have a culture or clear culture, we can move from the broader spectrum to a narrower spectrum agents. This is normally how we.
This is the questions that Dr. Ahmed said before. If we have a narrower spectrum, so we go to the narrow spectrum.
Yeah, definitely.
Okay.
We will go to the narrower spectrum, but we need to have a clear direction. I need to have a good response. I need to have a culture in hands indicating that I can de-escalate. And of course, we need to, as I said, we need to revisit the antibiotics we've started within certain period of time once we initiated, which is
and this does not increase mortality. This is important.
On the contrary.
Okay, on the contrary.
When they started to evaluate the de-escalation or not to de-escalate, they found the mortality in many studies, they haven't changed, but actually we found that the selection of the medication changed. The duration wasn't changed even, but actually better agents being changed, the price, the cost, which is we always look for it, has changed a lot, but definitely the mortality hasn't increased, definitely.
Why does the duration did not change? What do you think, Dr. Jamil? When we de-escalate, when you go to a narrower spectrum, it's true that the duration did not decrease, but why?
Yeah, for the duration, because you go with the diagnosis. So everybody probably know the duration. For pneumonia, for hospital acquired, probably 7 days, maximum 10 days. For community acquired, 5. So the duration does not change. But what changes is the duration of the patient hospital stay. And this is very important because the more the patients stay in the hospital, you get more, you get C. diff, side effects, bed sores, I don't know, secondary hospital-acquired infection. So that's where it makes, the mortality probably didn't change much, but really, and the readmission rate, the readmission for that patient is less if you go with the target treatment. So it's very important for now and the future for this patient and for future admission. But the one thing with de-escalation, I know that, our colleague from ICU, the antibiotic, it's kind of works like, it's anti-anxiety because you are comfortable. Patient really gets, for you, it's for you, not for the patient, because you are happy. It's, I'm fine, I'm go home. You will go home and you relax because the other antibiotic will work very well. This is where we have to convince them, be sure that the patient will be well. It's for you, not for the patient. So that has, to make the difference.
For this anxiety question, how will you deal with the culture negative result? You have a patient with suspected infection, you take your culture, you put the patient on 2 antimicrobials, and after 72 hours, the cultures come negative. What do you do?
واهلا بكم في فيديو جديد. النهارده هكلمكم على موضوع مهم جدا، وهو ان احنا نصلي ان شاء الله في الصف الاول في ميامن الصفوف وندرك تكبيره الاحرام.
عرفنا نلخبطكم اخيرا. كل الاجابات كانت كلها رسمي، بس ده ما لقيتوش الاجابه الرسميه. كويس كويس.
اوكي بس هو بيقول I will not de-escalate the antibiotic.
ده اللي جاي اصعب.
I will escalate and broadening the coverage. وآخر واحد I will de-escalate based on the results of the rapid diagnosis.
طيب هو it's good. You will not de-escalate except if the patient clinically improves. This is correct, but you have to search for what? Alternative diagnosis, alternative infectious diagnosis or non-infectious. Maybe there is another issue. Maybe there is CNS dysfunction or whatever. So this is important. Would you add an antifungal, Dr. Ahmed?
احنا وارد ان المزرعه بتاعتي تطلع نيجاتيف فور فانجل انفكشن، لكن في عيانين كتير كلينيكالي مش كويسين، مش امبروفينج، والكانديدا سكور بتاعه اكتر من 2.5. so for me I prescribe antifungal, especially in the critically ill. Again, surgical patient who receives TPN, central line, abdominal exploration, history of sepsis, I will prescribe it.
Dr. Frial, what is the yield of the culture? What is the usual yield of blood culture, for example?
It varies on multiple factors and basic things. Many times when clinician, they send the blood culture, there is 5 cc in one bottle.
So good volume, 10 cc.
Yeah. So even with good volume, like we come into the lab, how it is processed. So for example, in our hospital, we looked into and positive cultures overall from something like from all the culture that ascend is something like 25% to 40% in the literature as well. So this is one of the drawback to the cultures internationally. However, we are also looking into the clinical case, how the patient is improving. We look into the inflammatory markers, the biomarkers, if we are using, and how appropriate the cultures were taken. So these are all important in consideration.
Good. So the culture is one parameter which yields about 60% of the result usually. So it's not alone. You have to look into all the battery, clinical and inflammatory all together. And you have to look to alternative diagnoses. This is important. You don't rely that you give some so-called powerful antibiotic and you stop. This is another issue. When to stop? Generally, I know it is related to the type of infection maybe, but generally, you use procalcitonin to guide stoppage. 100%. 100%. Yeah. طبعا definitely. اوكي الدكتوره نرمين هتقول لنا اجابات اضافيه، اتفضلي.
Generally speaking, majority of the conditions with the antibiotics والstudies اللي اتنشرت or the publications said the average duration for antibiotics in general 8 days. 8 أيام دوت كان الرقم اللي ناس كتيرة أجمعت عليه. بتvary from 5 days, 7 days, depends on the diagnosis, depends on the antibiotic being used and the course itself. But actually, I think we are missing another answer related to the response of the patients and the improvements of the case or the deterioration of the case and so on. والdiagnosis itself بس مش هنقدر نربطها لوحدها بديوريشن معينة. We cannot say the duration is 7 days or 14 days. عندنا حاجات بتقعد شهور, depends on the diagnosis. We cannot برضو to correlate it 100% to the calcitonin أو procalcitonin للعيان. فاكشولي يعني هتبقى all of the above and others. الإجابة هتكون.
I think if we talk about ICU, there's good data on shortening treatment duration. But one of the challenges in ICU patients is when you stop short, like the medical ward, then you would have relapse after a few days and fever starts. So procalcitonin might be a good way of, if you have the money, the resources of that, that might be a serial of procalcitonin, might be a good antimicrobial stewardship strategies. But overall, now we came for lots of infections. Now we are onto the shorter durations, even in bacteremias. Mostly on the medical side, in the ICU, the challenge remains on with deciding the duration. But as Dr. Jamila said, for example, for pneumonias, hospital-acquired pneumonias, we have good data supporting that 8 days is adequate if you don't have Pseudomonas or resistant organism. So we have to keep on, always addressing shorter duration.
Yeah, the general concept that we have currently in infections, the shorter is better. Okay, that's general. For each diagnosis, you have, there is certain, like community acquired 5 days. This is exactly correct. When you have those mild, clear-cut cases and you know the patient, I start the antibiotic, within 48 hours, they respond, I switch to oral, that's 5 days, straightforward. The other part of the story is that when you have the sick patient in the ICU, complicated, and this is where probably hospital-acquired infection, even UTI, simple UTI can treat 3-5 days in female, male 7 to 10 days. But if they have it, with kind of sepsis, they have bacteremia, then I can say till the patient is better. And that's by clinical, plus your procalcitonin, where we repeat it every other day. And in the literature, just, Google it, you're going to go PubMed. There is certain algorithm for procalcitonin management for cases. It's different for community-acquired pneumonia than bacteremia. It's very nice, well done, but usually goes by clinical picture and procalcitonin to decide for you a couple of things. It helps in diagnosis, prognostic recovery for the patient to see what will happen, and to see the antibiotic when I have to switch or, oral or send home. So it's the clinical judgment. The general one, we have, certain duration for certain diagnoses.
Just want to add one thing. If you don't have clinical procalcitonin, then it's the clinical improvement. One of the challenging things in ICU patient is there are procedures. So there is this temptation while I'm doing the procedure, I kind of, continue giving extra doses, extra 1 to 2 days, because the patient will go for an ICD, better, he is very sick, let him get covered with this. So this is something also like we need to be aware of. And this is where the situation, resistance happens in this context more, when you have the lines and antibiotic pressure and no infection. So always remember this temptation, like you hold it back and have the courage and the gut to stop antibiotic at that point, and then maybe think of maybe a prophylaxis if going for certain procedures, surgical procedure, and go into more surgical prophylaxis site rather than insertion of lines and all that requires a dose of antibiotics.
How can we measure the adequacy of the AMS program itself? how can we have data regarding the adequacy of the antimicrobial stewardship program in the ICU?
Actually, we have a lot of matrices and a lot of indicators for the program, and we can use any of them generally for the hospitals or for any units, not even the ICU. We have things related to the quality, things related to the quantity, things related financially. So we have many things, and depends what you want to do with what.
What are the most common?
If you want to convince the top management, go for the financial one. يعني اتكلم على الconsumption and the money saving and things like that, so you can get the empower from the top management. If I want to convince clinicians, I need to go to the, for example, surgical site infections and the rate of the surgical site infections. And when I'm using the first generation cephalosporins, the rate hasn't changed. So it depends what you want to do. We have many things. For the consumptions, we can use the DDD, the defined daily doses, or the DOTs, for example. And even if we don't have this, we can even use the consumption, just the vials, the number of vials or the grams of the things, and convert it into monies. We have things related to the outcomes. So mortality rate, recovery rate. We can use things related to the hospital stay. For the quality things, we can see the number of interventions being done by the pharmacists. We can see the number of medication errors being identified through the prescribing process. We have many, many, many indicators can be used to evaluate the success of the antimicrobial stewardship. But the idea is I have an indicator with a figure. It's just a figure. The aim is how to use this figure and what's the target for it.
Okay. So, Dr. Frial, what is the ultimate goal of the AMS in the ICU as a conclusion?
I think so. We looked into, as you said, there are many measures that we look at, but the ultimate measure is to reduce mortality. Correct. And that's the very difficult to show in the literature. So that's why we go by reducing the resistant rates. And those are also not easy to show. Many often in ICUs, but there are the consumption of antibiotics, which are important as well. But we know this is one of the elements, and it's important to look for evidence of other outcomes as well. Like, so what we do in our hospital, we tie the infection control graphs and together with the consumption, and it goes beautifully. You have consumption, you have high rates, you have a strong infection control program. Your resistant rates also comes down, as well as you have good stewardship program. You will find it like CRE is less, MRSA is less, ESBL is difficult to show reduction in it, but and the other bugs you can easily show it if you have a bundle approach.
Okay. So the aim of the AMS is not just to reduce the consumption, it is to improve patient outcome. Reduction of the exposure to antimicrobials will reduce the antimicrobial resistance in your institution, in your governorate, in your country, and will have a better outcome for all of us. Any questions before we leave? Dr. Mustafa.
For example, in Pseudomonas campylobacterium bacteria and Klebsiella, all these things, if the team and bacterium is failing, what's your practice? Yeah, which it depends on the diagnosis. That's most of it. And usually those high dose types, like absolutely.
Similar, I mean, for Pseudomonas, I mean, if we have ceftriaxone tazobactam, we use it combined with colistin, and sometimes these are the major things that we use. We are good with the aminoglycoside. We don't have high resistance. So, but if we have pan-resistant Pseudomonas, then prayers is additional thing that we do as well.
No, we do it every time. Not additional. Every time.
Yes. The trick is to remove the line, change the line.
Definitely.
Look into that.
I think this
source control.
Source control is important.
And we have people surviving with source control. For CREs and others, we do still sometimes double the dose of meropenem, depends on the MICs, and then infusions, 24 hours infusion, or we do extended infusion as well in these cases. So some of these strategies combined, always combined.
What's the practice?
I'll just mention one thing. I think if you, just to conclude here, if you start a stewardship program in an intensive care unit, and by the end of implementation, piloting, still your ICU team are your friends, you are successful. You did it right. Otherwise, you need them to be on your side. Otherwise, you lose it.
I will tell you, most of the clinical pharmacists and the microbiologists are our friends.
And actually, I
I'm
need
sure.
to add, yes, something. Normally, when we start the antimicrobial stewardship, we end friends with the ICUs, but enemies with the surgeons. Yes, this is the normal scenario.
So we can do it.
Yes. Yes.
Or you can do what I have done, get married to intensivist. So
Yes. This is also another solution. Thank you all very much and hope to see you next year, inshallah. Thank you.